This is going to be on moving the needle on awareness of the Medicare Part D reforms. So I'm going to welcome Amy Niles, Chief Mission Officer from the PAN Foundation, as well as her panelists to lead us in the discussion. Welcome, Amy.
Good morning. We're going to do that over. Good morning.
Good morning.
That was much better. Well, on behalf of the PAN Foundation, I am really happy to be with all of you this morning. Thank you, Tommy, for setting the stage for our discussion. At the PAN Foundation, we couldn't agree more. The issue is access, and we have to put patients at the center of all of our policy discussions. I want to ask you, if you were to give access to care in this country a grade of A through F, what would you give it? And you can just yell it out. I don't have a poll. A through F. C? D? You read our State of Patient Access report that we just issued last week, where we actually poll people living with chronic conditions, ask them a whole bunch of questions, and ask them, what would you grade access to care? And on average, it's a C. But when you dive deep and poll certain communities and groups, access to care gets failing grades in many areas. So we have a lot of work to do. If you're a patient living with a chronic condition or a rare condition, it's a challenging environment. It's so challenging. You have rising costs all around you, and you face all these logistical barriers to accessing care. So I am Amy Niles. I'm Chief Mission Officer with the PAN Foundation. For those of you not familiar with PAN, we are a national charitable foundation and healthcare advocacy organization. We are on a mission to accelerate access to affordable and equitable care. And we do that in 3 ways: providing financial assistance, advocating for patient-centered policy solutions that improve access to care, and delivering education for patients and healthcare providers. I am really proud of PAN's leadership position when it comes to Medicare reforms. For more than a decade before the IRA passed in August of 2022, we advocated for changes to the Medicare Part D design, including the Part D cap and the Medicare Prescription Payment Plan. In fact, we pioneered conversations very early on around what I still call smoothing, some of you call smoothing. But since the IRA passed in August of 2022, we have turned our attention at PAN to education. Education around the Part D cap, education around the payment plan, and it seems from the poll that we just heard from Tommy, 93% of you believe that this education is really needed. So I'm very, very grateful to be here with some friends and colleagues who are going to join me in a conversation soon, and would just love for you to briefly introduce yourselves. Bill, we'll start with you.
I'm Bill Allen. I'm a member of the PAN Foundation Family and Friends Council. I'm a patient living with prostate cancer since 2004.
Good morning. I'm Susan Neff. I'm with the Pennsylvania Department of Aging, where I serve as the director of our state health insurance assistance program.
Good morning as well. My name is Dan Sherman. I am a financial navigator at a cancer center in Grand Rapids, Michigan. I'm also a consultant. I provide education and training to providers, oncology providers throughout the United States.
Thank you so much for being with us this morning. So let's turn our attention now to some research findings from the national poll that we conducted through the Center for Patient Research at PAN. In advance of the 2 reforms being going into effect on January 1, 2025, we wanted to gain a baseline understanding of how aware people on Medicare were of these 2 reforms. So we went out and did our first wave of research in June of 2024. We sort of had a feeling when we went out what the results were going to be, and I'll share them with you in a moment. When we went out in June of 2024, we committed at that time to do a second wave of research because we wanted to see, after the reforms were implemented, had we made a difference in terms of awareness. So I know you can't read these slides very well, but we did these 2 waves of research, one in June of 2024, one in January 2025. These were online polls that we fielded with the help of the Harris Poll team, a very credible research renowned firm. And these were individuals who have both traditional Medicare as well as people who were on Medicare Advantage. So there is good news. We certainly need a little bit of good news today. We've made some progress on the awareness front. Now, back in June 2024, when we fielded this poll, we found that 1 in 10 people on Medicare were aware of the Part D cap and the Medicare Prescription Payment Plan. We weren't really surprised by these findings, but what we're finding now in January, and again, this was the first month of implementation of these reforms, we now see that about 4 in 10 people are aware of the reforms. So that's progress, and many, many want to learn more about the reforms and whether they'll be beneficial for themselves. But even though we've gained some momentum on the awareness front, we see that there really is room for a lot more education. In fact, about 9 out of 10 people are familiar, somewhat familiar with the reforms at best. And we find that about 50% of the people on Medicare do believe that the reforms will be helpful in some way to themselves. This statistic didn't change from June 2024 to January 25. So let's look now at the Medicare Part D cap. When we polled about the Part D cap, unaided, which means we didn't offer them a description of what the Medicare Part D cap was, 1 in 3 said, yes, I am familiar with the Part D cap. When we provided a definition of what that meant, as you would suspect, this jumped significantly in terms of the awareness. Now, the individuals on Medicare told us that they heard mostly about the Part D cap from television, and we did see some of that. I don't watch too much television, but when I tuned it in, I did see some commercials that talked about the Part D cap coming in 2025. And they also heard it from their Part D plan, their insurer, which we would have guessed. But we see here that there is really a lot more room for education around the Part D cap. We even tested certain statements when we went out and polled. The first statement that we tested was the Part D cap ensures that one won't pay more than $500 in out-of-pocket costs for the benefit year. And the second statement we tested was the cap does not apply to people who are enrolled in the Medicare Prescription Payment Plan. So what we saw over time was that more people answered these 2 questions appropriately, correctly, but yet, gosh, there's a lot of people who still need that information about the details of the 2 reforms. And 6 out of 10 think that the Medicare Part D cap is going to be helpful. So I think the Part D cap is particularly helpful for the individuals with rare diseases, chronic diseases. They're used to spending thousands and thousands of dollars out of pocket, and now that has come down to $2,000. It's going to be very beneficial for that individual. Tommy also talked about the peace of mind that it gives people. That is true. You know, you never know when you may be diagnosed with a chronic disease or a rare disease, and having that peace of mind is very helpful. So let's turn to the Medicare Prescription Payment Plan. And here, too, we have made progress. About 1 in 4 people on Medicare were familiar with the Medicare Prescription Payment Plan. And most of them have heard it from their insurer, their plan. Not a surprise. That is where they're going for information. They are supposed to be calling their plan, going online to their plan to opt in. But yet 4 out of 10 people are really not understanding the details of the Medicare Prescription Payment Plan. It is complicated, as Tommy had mentioned. And here is that statistic that we just spoke about that I'm very concerned about. 1% of the people we polled have opted into the payment plan to date. Now remember, this was in January, very early. We have a long way to go to gain our learnings. 3 in 4 are unlikely to do so, they say. Well, maybe that's because the people we polled really didn't have high costs, and they don't find the need to opt into the payment plan. Or maybe they just don't know anything about the payment plan, and they're just going to not bother with it. We're not sure. But, you know, I'm worried about the people for whom this payment plan may actually be really beneficial. And are they getting the information they need to opt in? We'll talk more about that. So the implications, again, it's early in the plan year. I haven't seen data put forth yet from CMS to give us a profile of who's opting in, how many, and you know who these patients are. But there seems to be a consensus that we have a big information gap and a big need for more education. Many of us who worked on the payment plan prior to its implementation, we had many conversations with CMS. PAN worked with other leading patient groups, many of which are in the room today. We were really hopeful for a reform that would be simple, that would be implemented smoothly. And we did not get that. This reform is complicated, and we're going to see lots of bumps along the way. There are questions that we don't really have all the answers to yet. So we have a lot of learning to do. But because it was so complicated was the reason that we launched at PAN our national campaign around the reforms back in October. And this campaign was multifaceted. We did a radio tour, many speaking engagements. We created all kinds of resources, online, booklets, videos. And you know, with that campaign, well, we've reached more than 58 million people with information, but yet what we're hearing is that we have a lot more education to do and a lot more outreach. So, let's turn to our conversation. So, Bill, I'm going to start with you. You're someone who I think the Part D cap would benefit, and I know you've opted into the Medicare Prescription Payment Plan already. Talk about your experience with that to date.
Well, the first thing that you encounter being retired and then having to wanting to have access to your medication, which is very expensive for my disease. The most difficult thing was you get undulated with a lot of paper at the beginning of the October enrollment period. You're getting your annual notice of change from Medicare. You're getting your, if you have a supplemental or an Advantage plan, you're getting information about, you know, and from agencies to pick a plan. So there's a lot of salesmanship going on at this time when you're trying to make a decision. The other thing is then you're getting, and you are aware of this prescription medical payment plan as well that's coming in, but you don't know quite how that's going to work. And so in my household, I'm on Medicare with an insurer or supplement. My wife is on Medicare with another insurer. I got a letter in the mail. She got a conversation from a physician assistant in the doctor's office. She felt like, I don't know what this means. I got a 5-page letter. And I'm trying to read through and make a decision, do I opt in or opt out? We never thought to communicate together because we thought this only applied to my plan. And when I asked her about it, she said, I had no idea what it meant. She said, the nurse just said, you can do this, and I have my paperwork, and we never really shared it. So that's a lack of communication just in a household. So can you imagine what the communication is in mass? So I found that rather difficult. The other question I had when my decision was, do I opt in, do I opt out? Now, my biggest medical cost is my cancer drug, and luckily, I get a grant. So now I'm saying, will that mess up my grant? Will it be included? Are they going to count that toward my deductible? They're going to count that as my $2,000. What credit do I get any at all if I opt in? I'm not sure of this. So I close my eyes, take a chance, and I opt in. And just before coming here, I got a bill in the mail for $11.19. So I'm thinking, okay, is this what I'm supposed to get, or is this for something else? But it really was confusing, and I would suspect that it will continue to be confusing.
And that bill, I think, is a challenge with the payment plan, because when you opt in, you're now receiving two bills from your plan, right? You're getting your premium bill and you're getting your bill for prescription medications. So it's a behavioral change for many. And we always say, well, if you have affordability problems, make sure you pay that premium bill first so you protect your coverage. But it's a challenge. And I think you shared earlier, when you got that bill for $11, you weren't quite sure what medication that covered, or there weren't many details. Is that right?
Yeah. The letter didn't cover where the charge came from at this point. So I don't know whether I missed it, or this wasn't included, or it could have been a smaller amount for the charge. I don't know. It's confusing.
So Sue, you are on the ground. You are talking with people on Medicare every single day. What are the barriers you're seeing in terms of awareness around the two reforms?
So for those of you who aren't familiar with what a state health insurance assistance program does, it's a nationwide program. Every state calls their ship something different. Here in Pennsylvania, we refer to ourselves as PA Medi. And our mission is to provide unbiased Medicare counseling and education to beneficiaries. And also we're supported by MIPA, which is the Medicare Improvements for Patients and Provider Act. And the mission of that grant is to enroll people in LIS, which is extra help for Part D, and also the Medicare savings programs, and also do education to the general public about Medicare's preventative benefits. So in the course of our day-to-day activities, the SHIP, PA Medi, are located in Pennsylvania's 52 area agencies on aging. So we have a team of about 300 people, we have 52 staff, and then the rest are very informed, highly trained volunteers that provide these services. So the main barrier we see to it is there's just a poor health literacy amongst Medicare beneficiaries. So we try to overcome that with easy to understand information. And, people are very appreciative of the changes in Medicare Part D, but they're saying that, this prescription payment plan would have been a little bit more helpful prior to the cap. And when there was a donut hole, it would have been much more, useful then. They do appreciate that there is that option now, though. So, that is the main barrier. There's a lot of confusion. And then we also see that some of the point of sale at the pharmacy, they're not aware of the program either, but hopefully that's something that's changing as well.
You mentioned the Extra Help program, and I just want to take a moment. This is a fabulous federal program, also known as the Low Income Subsidy Program, really low awareness around this program as well. In fact, CMS estimates there's at least 3 million people in the country that are eligible for extra help but don't know about it or haven't bothered to apply. And it's really important because if someone is eligible for extra help, they don't need to bother with the Medicare Prescription Payment Plan. They shouldn't bother with it. So there's a lot of education around all of this that's needed, right?
Most definitely. And in Pennsylvania, we are very fortunate to have a prescription assistance program that hits the people that have too high of an income for the LIS. It's called PACE, and it is supported by Pennsylvania lottery dollars, and we're very fortunate that we have that in our state. And it serves about 300,000 people who fall in between, being eligible for LIS. So they wouldn't need the Medicare payment plan, prescription payment plan either.
May I say, I'm going to say something about that. So some statistics on LIS, a low-income subsidy program. So approximately 30% of all Medicare beneficiaries qualify for this program nationally. So you have to be below 150% of the federal poverty level. So 30% of the Medicare population is below 150% of the federal poverty level. And then, as you mentioned here, somewhere between 30 and 50% of people that qualify for low-income subsidy, that 30% category, are not enrolled. So education is a huge issue here when it comes to that specific program.
So Dan, let's continue with you because you are on the ground as well every single day as a financial navigator. What are you hearing from patients around these two reforms? I know you have a lot to say.
Well, that's going to be a simple answer. And I mean, so far in the year, right, we're early, but I have not heard one thing from a patient. There has not been a single person that I've spoken to that is aware of the program. And now I've approached patients about the program, but there just isn't knowledge about it. And it's a scary thing that patients are not aware of it. It's even a more scary thing that when I actually go and speak to pharmacists about this program, they look at me and going, don't know what you're talking about. So we have a long ways to go when it comes to education about this program.
So when you're not hearing from patients and you're thinking to yourself, this patient actually may benefit from the payment plan, what do you do?
Yeah, certainly educate the patient. Now I'm going to go through a process of my own determination of who I think would be beneficial, or this will be beneficial for. As we already mentioned, I'm going to rule out low-income subsidy first. That's going to be my first step. Make sure that they don't qualify or that I enroll them if they do. My next step is not going to be the payment plan. My next step after that is going to be your program, right? So I'm going to be looking for a copay assistance foundation. If there's not one open, we all know they open and close, right? Based upon funding, I am putting them on your waiting list. I'm putting them on my own waiting list, right? So other foundations like Patient Advocate Foundation, HealthWell Foundation, all of these other ones, they don't have their own internal waiting list. So I do, and as soon as I see something open up, I'm attacking it and trying to enroll them. The next level after that is going to be the payment plan. That if the patient is saying, listen, I'm going to have a $2,000 copay in January or February, whatever it may be, and I just can't do it, then the logical step for me is, hey, this is available for you. There are some patients that I'm going to be wrestling with. We're going, well, I have another thought for you, which is if you can afford it, and based upon my experience with copay assistance programs, like, hey, I predict that in the next month, one is going to become available, right? Then I might say, well, let's see if you can pay your large copay, retroactively enroll people into a copay assistance program, and then get reimbursed directly from from the organization. It's going to get a little bit more complicated, in my opinion, that if we do it in the reverse. If they enroll into the payment plan and then 2 months later, 3 months later, I get them enrolled into a copay assistance program, now the patients have to get reimbursed on the monthly basis the different the different copays that they have to pay. And so it gets a little bit more complicated. So my preference is going to be copay assistance.
It's an interesting point because I think the preference, likely on behalf of all foundations, is that we would prefer not to be in a situation where we're reimbursing every month back to the patient for what they need to pay to the plan. We will do that if presented with that, but it's not ideal. I don't think it's ideal for the patient or for the foundation. So in your mind, and then I want to turn to Sue and Bill, what you're going through with a patient is, one, is extra help appropriate? Do they qualify for extra help? You're thinking about foundation support, and then you're thinking about the dollars that they may need to pay. That's sort of the steps that you go. Is that a fair representation of?
You're asking me?
Yeah.
Yes,
Okay.
absolutely. If the patient says, boy, it's going to be a hardship, it's going to be difficult, but I can do it, I'm going to be honest with you. My gut feeling is if I have a high level of confidence that I can get them copay assistance retroactively, then I would prefer to do that before we do the smoothing program. Now, please don't misunderstand me. I think the smoothing program is highly beneficial for people, but it's going to be more highly beneficial for people who are at a little bit higher copay than a $100 copay or a $50 copay, right? CMS has put it at $600. I'm not quite sure that's the right number, and we can probably talk a little bit more about what the right number is.
Yeah. Sue, who do you think is the ideal person for the payment plan, if there is one?
Certainly, it's people who might have a lot of spikes throughout the year in their prescription costs. Also, people who their income increased so that they're no longer eligible for LIS or PACE. And we found the most useful tool to show people is to actually use the tool that's on Medicare.gov. It's a worksheet where we show people here's with the plan and without, much like Tommy showed. And so the few people that we have enrolled into the Medicare Prescription Payment Plan is because they saw the difference that it can make to their monthly costs.
And Bill, what do you think?
Having to be a patient in a doctor's office, and he prescribes a medication to you, and he tells you that medication is going to cost you $15,000 a month, that's an eye-opener. And it's rather frightening, because that may, and I'm thinking it may not be the only cost just for me, but there are people who have multiple diseases at the same time with a medication that's going to cost either twice as much or the same. So it's really scary. I'm retired, so I plan for my retirement. So I plan to live and pass away, but not to pass away to live, because these medications are really expensive. So I think from my perspective, when I look at the help that's needed, a lot of people will need it, regardless of perhaps your income at a certain point. I'm not a rich person, but something without a PAP would be devastating. You know, my wife and I wouldn't be able to do any of the things that we had planned to do because we didn't plan to have these costs to come up in our retirement age. So it's a difficult thing. So when you have the opportunity for an organization that I go to, my provider, that does the kind of work that Dan does, it's beneficial. You know, I kind of feel like they're looking out for me. because otherwise I would not know where to go to get that kind of help. So I'm thankful for folks like Dan and Amy who can do that for patients, and for doctors who help patients navigate this world of high drug costs.
I think, Sue, you mentioned at the start one of the biggest issues was health literacy. I think it was you. We have people who are coming from such different backgrounds. You know, we have people in rural communities. We have non-English speaking individuals. What strategies have you implemented or have you seen that may be beneficial in creating greater awareness and helping individuals with these reforms?
We are experts at finding those different ways to reach people. For example, we partner with National Federation of the Blind's Newsline. It's a digital access platform for people who are print impaired, whether it's a visual impairment or otherwise they can't read print. We reach people that way. We translate our materials into the top 6 languages other than English spoken in Pennsylvania. We have requests for different language translations all the time. We just translated things into Polish. We leverage the power of since we're the state unit on aging, we have a communications department who facilitates press releases that go to all the media outlets through the state. It's a no-cost means, and we educated the public about the Medicare Prescription Payment Plan, the other changes to Medicare Part D. Like I said, we have a network of over 300 counselors in the Commonwealth, and they're all educated, so they do outreach events, they do enrollment events, so we try to reach people in many, many ways. We also do digital. So we have a Facebook page if you want to look up the Pennsylvania Department of Aging. We have some wonderful posts about the changes to Medicare. And a recent post that we did about the Medicare changes was one of the highest posts ever. We had 55,000 click-throughs to our website. So that's another way that's very low cost for us. We also spend money through our grants. We do direct mailing. That's a very, very effective way. We also just encourage people to review the notices that you get, that annual notice of change. A lot of people don't even realize that they get that every year. So part of the education we do prior to open enrollment in the fall is to let people know you're going to be receiving these notices. If you're not sure what they are, come to us. We can help you explain to you what they mean. So we try to do outreach. Tommy had mentioned working with independent pharmacies. We have an initiative that we're doing right now with a company called Medibag. They're the ones that produce the prescription bags for the independent pharmacies. So we're going to print up bags with information about extra help and all the different things from Medicare Part D. So that's a very important partner in the rural areas of Pennsylvania. Here in Philadelphia, we partner with an organization called Fabric Health, and they do outreach for social services programs in laundromats. So we just love finding new ways to reach people to get that messaging out there. We also are really dedicated to providing education in plain language. Typically, we've found that our materials are a little bit too confusing for people, so we've taken the CDC's and CMS's plain language courses, and we're in the middle of retooling all of our outreach to make sure that it is plain language, so it's more easily understood by the general public.
Those are terrific, and thank you for all you're doing. I think many of us who work with CMS were hopeful that when the reforms rolled out, we were going to see a little bit more robust outreach and education. And I think we've been disappointed. And so these kinds of efforts are really important. Dan, I want to turn to you because I know you and I have talked about the challenge. So many people don't know where to turn. They don't have advocates helping them. What strategies would you recommend? What would you recommend to this group to try to create greater awareness?
I think I can only answer that question in the context of how I'm employed. I work in a cancer center, right? My role is to reduce financial barriers for cancer patients. And so I'm going to answer that question from a provider perspective. All right. So if we're going to be taking I'm going to use the word financial toxicity, right? The distress that our cancer patients, or it doesn't have to be a cancer patient, but high dollar medications. If we're going to be taking financial toxicity seriously, we need to take it seriously. And we need to be addressing this with our patient population. I think on the provider level, we do a fantastic job of preparing patients for chemotherapy. Right. Here's what's going to happen. You're going to experience these side effects. You're going to experience nausea. And so rather than waiting for you to experience nausea, we're going to proactively treat it, right? We aggressively treat the toxicity. But for some strange reason, in most healthcare settings across the United States, we don't take the same approach when it comes to financial toxicity. We wait for it to happen, patient is in crisis, and then we try to, let's go after free drug, right? So for me, it's education on the provider level. We need to figure out, this is a new program, so we need to figure out what's the threshold. When should we approach a patient about educating them about the prescription payment plan? Should the cost of the drug be $2,000 and above, whatever? Because you remember, you pointed this out, you're paying 25% of the cost of the drug typically in Medicare Part D. So 25% of $2,000, that's $500 if I added it up correctly. So is that the threshold? We need to figure this out. But I'm of the belief that education should be happening on the provider level of all of this. And so here's what I want to say. Being proactive about this rather than reactive. And so approaching patients as soon as that prescription has been written by the provider, a message is sent to the financial navigator, advocate going, hey, this is going on. We go either call the patient or see the patient while they're still there and educating them, what should we do here? LIS, copay assistance, prescription payment plan. One more thing, and then I'll let other people talk here. But the approach that I teach when I go and provide education to providers on how to do financial navigation services is, what is the problem that we're dealing with? Well, the main issue is that people have high copays, right? That's the problem. How can we fix that? Is there a way to fix that rather than just keep putting Band-Aids on the sore? Now, Band-Aids are good, copay assistance is good, but is there a way, if we had people in this role who are truly experts in Medicare, and Medicare Part D, and low-income subsidy, and understanding how these systems, what's the differences between Advantage plans and supplemental plans, and how does that affect the patient? And being proactive and educating patients on not that the financial navigator is selling insurance to people, but we're educating them on, I'm just give an example. If you pick supplemental plan G, you're going to owe $257 for your medical care for the year. If you pick an Advantage plan, well, in 2025, the max out of pocket can be as high as $9,350. That's a big difference between the two. Why aren't we being proactive in addressing this when people can enroll into these plans to prevent the problem? And I think we need to be taking the same approach when it comes to the prescription payment plan. We need to be there right away. I'm a little concerned about the patient showing up at the pharmacy and then the pharmacist says, well, this is a $2,000 copay. How do you want to pay that? Oh, well, you can sign up for the prescription payment plan. Well, how does that happen? Well, they have to call the insurance company, right? and then work it through. So it's going to take a day or two before that happens. Now they have to go back to the pharmacy, pick up the prescription with a reduced price. I mean, it's okay, but why not do it proactively and doing it on the provider end?
I think point of sale would absolutely be a big improvement. Bill, before we turn to next question, I think you said your wife was the one who had the conversation with her physician assistant, but you didn't have a conversation. Is that correct?
No, I did not have a conversation with my physician about the plan. I learned from it from being a part as an advocate. So being an advocate put me in a position that at least I knew it was coming down the pike. So I went looking for it. I went to look for it on the Medicare website. I went to look for it on my insurer's website. Didn't see it on the insurer's website. That's why I got the 5-page letter. But I did see it on the Medicare website. So I kind of knew it was coming. But what as a individual, you want to know, well, where do I go from here to make it work? And even as an individual, how can I help other people? Now that I'm in a role as an advocate, and I've talked with Amy about what can I do individually, not only as a patient, but as a receiver of the benefits that I have and the knowledge that I'm gaining. My background is property and casualty insurance, so I know a lot about acronyms and policy language. This language here is totally different. So I'm learning a new language around advocacy, around the use of understanding how the Part D Medicare works, and it's difficult. And I'm sitting here listening to Tommy talk, and I'm thinking, what have I got myself into? I'm learning all over again. But I know that this work is very, very important, or I wouldn't be sitting here. So the little things that I can do is like putting on my Facebook page that I'm an advocate and I'm a part of the PAN Foundation. Make a notation on my LinkedIn page that I'm attending this conference and that I am also an advocate on the PAN Foundation. And I'm getting these people who know me will like it, and they will send me comments. So I know I'm reaching someone out there that I'm telling them, go to these websites, get the information, learn what's going on. So those are the little things that I can do. And then I'm beginning to talk to community organizations in my state. I live in the state of Maryland. I have a relationship with a gentleman who pushed together talks for black men around prostate cancer. And so I've been invited to, I have done one, talk to a group of black men about prostate cancer, and then at the same time share what I know about the PAN Foundation and its level of education that's out there. So I'm hoping that I can do more talks on an individual level. And I kind of think that's where it begins as well. And Amy and her folks got a cadre of council folks like myself who are out there in various states doing this kind of work. So I think it's going to be a way to make it happen.
And Bill, I just want to say thank you for all that you're doing. You are, I think, one of the best advocates I have come across in a long time. We just have a couple of minutes remaining. I want to throw this closing question to all of you. If you had the opportunity to speak to Congress or to speak with CMS today or tomorrow, what would you recommend? What changes would you like to see either with the Medicare reforms or the Medicare Part D design in general? Who would like to start?
I will start. I'll take that one. We wish that they could change the name from Medicare Prescription Payment Plan to option instead of plan, because the word plan also is used for standalones for Medicare Advantage and Medigap. So if they could say option instead of plan, that would be wonderful. And I wholly agree with what Tommy presented earlier about the standalone plans. We hope that CMS can bolster them because there are still people who want to have Medigap with a standalone. They don't want to go to Medicare Advantage. We're seeing we only have 14 left. And we see the prices of those plans, their premiums are very, very high. So we hope that CMS takes some action to bolster those standalone plans.
Well, I'm going to go back to education. And, currently, I believe, and correct me if I'm wrong, you might know this, or Amy, the education currently is set up that it's either going to be the insurance company that provides the education, or is the pharmacy. I don't think there's any requirements that the provider is going to be providing education. Let's just be honest here. The insurance companies are not excited about this program, right? I mean, does somebody, who has the statistics on, insurance companies have already calculated how much they're going to lose on this, right? Because there's no, there is no meat behind the requirement for the Part D enrollee to actually reimburse the insurance company. The only thing that can happen is that they'll kick them out of the prescription payment plan. I think I read somewhere that they're predicting at least a 30% loss in this, that they're not going to get reimbursed. If somebody has different numbers on that, please speak up, because this is off the top of my head right now. I know providers might not like to hear what I'm going to say, but I would like that there actually is a requirement that providers need to provide education about this, once again, at a certain threshold. It can't be for every single prescription, but for me, to be as proactive as possible is what's going to be the most beneficial, and you can't be more proactive than at the time of writing the prescription. So.
And I know when it was rolled out, CMS did have plans to conduct outreach. Wasn't a requirement, but they talked about outreach with some of the specialty providers who would likely be prescribing some of these high-cost medications. I'm not clear, how far that outreach went. Bill, closing thoughts in terms of any reforms you'd like to see.
I guess I'd like to see reforms around pre-authorization. Also, the step therapy, yeah, particularly that, because that really puts patients on their heels until they're able to get what may be the medication that they need down the road. So that's really something that I think Congress needs to act on. Clinical trials, for instance, especially in my community, the need for Congress to look at making clinical trials accessible and easy for a diverse population to look at those opportunities and not be fearful of any particular outcomes. So I look to Congress to make those kinds of things happen.
And those are all areas of focus for us at the PAN Foundation. We are concerned, Tommy, about the increased utilization management that we're already starting to see, the prior auth step therapy, and I fear that it's just going to continue. So all of us have a lot of education to do, and we have a lot of learning to do this year as we see how this is rolling out, and hopefully we'll see a day where it is being implemented a little bit more smoothly. I had to throw that in. So please join me in thanking Bill, Sue, and Dan.
Awesome. Thank you all so much. Do we have any questions from the audience for the panel? Ooh, yes, coming over here.
Really hard to see it.
Yeah, right here.
Thank you, guys. So one question that I have that's coming from multiple centers of excellence, medication access coordinators, biologic coordinators, and offices that we're getting is how you handle the foundation grant. So just case scenario, say I did enroll my patient in M3P. We are now at month 3, month 4. A grant came out. I would rather pay off that amount. I don't want these monthly bills and having to figure that out. So I'm trying to understand, do we unenroll the patient and make this one-time payment? Do we call the plan and say we want to pay it off with this grant? And the second piece of that is I've only seen one solution that can electronically enroll patients in smoothing, but I don't know if these things can unenroll or, that I know the process of unenrolling, but I think if you can help me answer just that grant piece, right? I want to touch that patient as least as I can to make sure that they don't keep continuing to get these bills if we did enroll them on that high drug. So if one of, how is PAN handling that, or what would you suggest?
And I think, Melissa, this is an area where there's just going to be a lot of learnings over this year because we do have questions about how it's working on the back end. I would say from a PAN Foundation perspective, if someone, and that's a big if someone can get a grant from a foundation, whether it's PAN or any other foundation, they may not need the payment plan, and perhaps they don't enroll. The challenge, I think, becomes when someone has multiple chronic conditions and may need access to multiple grants that may or may not be available. So, in that regard, it might be better for the patient to opt in. They can opt out at any point. It's a challenge. It's more work, for sure. But, generally speaking, at PAN, we're messaging that if you are eligible for extra help, enroll. If you can get a grant, and you may not have to worry about the payment plan. Dan, I don't know if you have anything to add to that. I know you don't work at a foundation.
Yeah. No, Melissa, this is what I've been struggling with over the last 5 months that I've been looking at this is, the example that you had, let's do an oral oncolytic, right? $15,000 medication. So the $2,000 max out of pocket is going to be met in January. If they're enrolled, it's going to be $166.67 every single month. And that $2,000 max out of pocket has now been met, even though they're paying $166.67. So even disenrolling them out of the program, at that point, it doesn't matter because the $2,000 max out of pocket has been met and there's no new patient responsibility being added to this. It is an interesting idea that you just mentioned, which is, can we get the insurance company to say, we want to pay this off in full and get a bill for that? That would be nice if you can secure copay assistance for them retroactively. So if anybody, I don't know if that's possible yet. Maybe there's some adjustments that can occur, but that would be one solution to it.
I think we have a question over there. Nope. Any other? Oh, Esley, right in front of you.
I don't really have a question per se, but I just want to thank Amy and the panel for all the programships that you guys have and the hard work and the education that y'all are pouring out to patients that are really the ones that are, I guess, suffering because of all these changes. But thank you, and even everybody in here, just the hard work that you guys in helping us, move the needle down the court. So thank y'all. Appreciate it.
Appreciate it. Thank you.
Any final questions? Oh.
Hi, my question's for Amy. There's so much that PAN does to help patients across multiple diseases. with the changes in the out-of-pocket caps for Part D patients, I know that you've made some changes to the grants. I'm just wondering if you can speak a little bit more to that. Like, I'm so curious of if you see more opportunities to help substantially more patients, just a little bit more kind of behind the scenes you're thinking about essentially an opportunity to help more patients.
Thank you for asking that, and I agree with you. There is more opportunity. So yes, while some assistance declined because people on Medicare will no longer pay more than $2,000, it's not so straightforward because there may be Part B, as in boy drugs, that individuals need access to. So we have to look at that from a foundation perspective to kind of find that sweet spot that's going to help the most patients. But to your point, while a couple points. One is $2,000 is a step in the right direction, right, for millions of Medicare beneficiaries, but for millions of Medicare beneficiaries, it's a lot of money. And people still need help. And so if our contributions stayed the same, gosh, we could help a whole lot more people. And that's our goal. I think all the foundations have that goal because there's a tremendous need out there. Thank you for asking.
Perfect. That is all the time that we have for questions. So thank you again to the panelists.
Thank you.